بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, we are continuing the series of abdominal imaging, and the lecture of today will be about the imaging of the acute abdomen. And we have finished the lecture of abdominal anatomy, and we also discussed some issues about abdominal trauma. And now we will try to cover some of the diagnostic aspects of acute abdominal conditions, which should be unrelated to trauma, and they may require early medical or surgical treatment. Then we have a lot of conditions that can contribute to acute abdomen, and these include too many pathologies in the gastrointestinal tract, as well as in the solid organs in the abdomen and the pelvis, and also there are some causes which are located in the chest can contribute to acute abdominal conditions. And of course we will not cover all these issues in this lecture in particular, but I will enumerate some of the most common diseases, and I will handle some of these lesions, and most of the remaining issues will be covered during our talks about the gastrointestinal imaging. Then exacerbation of peptic ulcer, perforated peptic ulcer, gastroenteritis, inflammatory bowel disease, intestinal obstruction, Meckel's diverticulitis, intussusception, colitis, colonic diverticulitis, acute appendicitis, then cholecystitis, cholangitis, biliary colic, hepatitis, acute pancreatitis, splenic infarction, and rupture. Cases related to the urinary tract as acute pyelonephritis, ureteric colic, cystitis, and acute retention of urine. All these issues will be covered in details while talking about the imaging of the urinary tract. And retroperitoneal or peritoneal structures, peritoneal lesions like peritonitis, primary or secondary, gynecological lesions like torsion of the ovarian cyst, rupture of the ovarian cyst, ovarian infarction, salpingitis, ectopic pregnancy, degeneration of uterine fibroid, pelvic endometriosis, and severe dysmenorrhea. Vascular lesions like ruptured aortic aneurysm, acute aortic dissection, mesenteric embolus, mesenteric venous thrombosis, and ischemic colitis. And some of the extra abdominal causes like lobar pneumonia, pleurisy, myocardial infarction, sickle cell crisis, uremia, hypercalcemia, and Addison's disease. Of course, you know that the imaging of the abdomen can be performed by too many imaging modalities like the X-ray, the ultrasound, the CT, MRI, and we can use the angiographic facilities of CT and MRI in some particular conditions. Then the role of plain films may be somewhat limited, but actually in particular issues the plain film is one of the most important diagnostic tools. And plain films can show radiopaque calculi contributing to biliary colic or renal colic, for example. Calcification anywhere in the abdomen can also show the gas pattern in the intestine, and can help very much in the diagnosis of intestinal obstruction. Also foreign bodies and intraperitoneal fluid collections and pneumoperitoneum, as well as some of the bony abnormalities and organ enlargement, in particular the liver and the spleen. And these are examples of the urinary tract calculi. This is a small radiopaque calculus in the left renal area, and this is what we call the staghorn calculus in the left kidney. And these are two radiopaque stones outside the renal shadow representing gallbladder calculi. And this is what we call the obstruction series, or the radiological series for the diagnosis of intestinal obstruction. And we should have the supine and the erect film. And if the patient is unable to be radiographed in the erect position, we may obtain the decubitus position, especially the left one, to show air between the liver and the diaphragm. And the chest X-ray, frontal chest X-ray, is one of this series, which will help very much to show free air under the diaphragm, indicative of pneumoperitoneum, and it may show basal pneumonia and also some the presence of pleural effusion. Then whenever you have a case of clinically suspected to have intestinal obstruction, one of the valuable diagnostic tools is to obtain a plain X-ray of the abdomen while the patient is in the supine position, and another view while the patient is in the erect position. And in the supine film, you can see the intestinal loops, which are markedly dilated and filled with air. Then in the erect position, you can see multiple air fluid levels, and this appearance is diagnostic of intestinal obstruction. According to the shape of the bowel loops, you can easily identify the level of the obstruction by the plain films. And here you can see the classic appearance of the jejunal loops, and you cannot see the ileal loops, meaning that the obstruction is between the jejunum and ileum, meaning that is small, proximal small bowel obstruction. And this is a mechanical obstruction after appendectomy. And you know, postoperative adhesions are one of the most important causes of intestinal obstruction. And here you can see dilated jejunal and ileal loops, meaning that the obstruction is distal to the site of the ileocecal junction, or maybe at that level in particular. And in this patient, the lateral decubitus showed multiple air fluid levels, as you can see. Then the causes of small bowel obstruction are too many, and there are a lot of intrinsic causes inside the bowel itself and extrinsic causes outside the bowel. The intrinsic causes include intussusception and the strictures, whether surgical or post-irradiation, neoplastic lesions like carcinoma, carcinoid, and lymphoma, inflammatory lesions like Crohn's disease, ileocecal tuberculosis, and intestinal ischemia, mural hemorrhage, post-traumatic or due to overuse of anticoagulant therapy, then foreign bodies like bezoars and gallstone ileus, and the meconium ileus in the pediatric age group. The extrinsic causes include fibrous adhesions, abdominal hernia and incarcerated hernia, the volvulus, abdominal masses, intra-abdominal abscesses, abdominal aneurysms, hemoperitoneum, and endometriosis. Then, as I have said, you should have, whenever you suspect or there are clinical suspicion of intestinal obstruction, you should have the supine film and the erect film. In the supine film, you can see the intestinal loops, which are dilated, filled with gas, and in the erect film, you can see the air fluid levels. From the shape of the intestinal loops and the mucosal pattern, you can identify the type of the dilated loops, and you can also know the level of the obstruction. And the radiographic features of small bowel obstruction will include dilated loops filled with air and fluid levels. The loops are usually central, and visible valvular connivence which are the mucosal folds of the jejunum, and sometimes you can see this sign, which the string of beads sign, meaning that in the erect film you see only some of the air which is trapped between the valvulae connivents, giving this particular sign. And this is an intestinal obstruction. This is the supine film, and this is the erect film, which shows multiple air fluid levels. Then intestinal ileus, which means that this is functional intestinal obstruction, occurs immediately in the post-operative early hours, and the bowel sounds are absent or hypoactive, and this is a well-known condition, especially following surgeries, and it takes few hours, and the ileus relieved. Then other causes of ileus include the peritonitis, hypokalemia, hypothyroidism, vascular occlusion, and this will result in functional obstruction of the intestine. Then in the supine film, you can see here the some gas shadows which can be attributed to a normal appearance, and in the erect film you can see some small air fluid levels, as you can see here. Then mechanical intestinal obstruction, the most common by far is adhesions, and these adhesions may follow surgery, very common, or maybe the sequelae of irradiation, or other inflammatory conditions which may result in adhesions between the intestinal loops. Then incarceration of some of the intestinal loops in a hernia, for example, or a intestinal volvulus. Also some neoplasms and gallbladder stones whenever they perforate the gallbladder and pass into the intestine, and of course in cases of intussusception. In cases of mechanical small bowel obstruction, you can see dilated small bowel loops and little gas in the colon, especially in the rectum, with dilatation of the small bowel and multiple air fluid levels in the erect film. In patients who had the CT examination, you can also see the same findings, and here the small bowel loops are markedly dilated, they are distended with fluid, and you can appreciate some air fluid levels in the dilated intestinal loops. One of the values of CT scan is that you can exclude any detectable mechanical obstructive lesion like intussusception and tumors, for example. But in many cases you cannot see an obstructive lesion, and in this condition you may assume that the cause of obstruction is most likely the sequelae of adhesions, especially if the patient had a history of previous abdominal surgery. Then in this case you can see dilated small and large bowel loops, and the erect film shows multiple air fluid levels, and you can appreciate the large bowel by the peripheral location and the rostral pattern and the long length of the air fluid levels. Then in this erect film you cannot appreciate the cause of obstruction, but here in the CT scan of the same case, and these arrows point to a malignant stricture in the sigmoid colon, which has contributed to the obstruction of the bowel proximal to it. And in another patient, then you can see a hugely distended bowel with gas in the supine film, and the CT scan showed the presence of dilated large bowel. The small bowel is not dilated, and in the region of the rectosigmoid colon, and you can see this neoplastic growth with extensive colonic mural thickening markedly encroaching on the colonic lumen. And here is a case of Crohn's disease with small bowel obstruction, and you can see this loop of the small bowel with significant mural thickening and enhancement of the wall, and the proximal obstruction of the or dilatation of the intestinal loops, and you can also appreciate the presence of multiple air fluid levels. The midgut volvulus is an easy diagnosis if you can see this particular sign, which is known as the whirlpool sign. And this sign is appreciated at the root of the mesentery, where you can see the superior mesenteric artery and vein. And here this is a very good presentation of this particular sign, where this is the site of the superior mesenteric artery and vein, and you can see this whorls in the site of the root of the mesentery, and you can appreciate the markedly dilated small bowel loops with multiple air fluid levels. In gallstone ileus mean that the gallbladder is inflamed and there are multiple or single gallstone that has perforated the wall of the gallbladder and has came inside the small bowel. And the stone will pass through the small bowel, may be trapped near the ileum or near the distal ileum, and in this location you will see a proximal dilatation of the small bowel with multiple air fluid level. And we have a diagnostic triad which is known as regular triad of a small bowel obstruction and gas in the biliary tree because of the perforation of the gallbladder inside the gastrointestinal tract, and the presence of a large ectopic gallstone, meaning that the gallstone is in the small bowel. Then the gallbladder is usually collapsed. It may contain gas which has got an access into the gallbladder via the intestine, with impaction of one or more gallstones in the small bowel. Then this is a good example of gallstone ileus, and you can see this radiopaque stone within one of the intestinal loops. The proximal loops are dilated with some air fluid levels. Then the goals of imaging in cases suspected to have intestinal obstruction in general is to confirm the diagnosis and to differentiate mechanical from functional obstruction, and to determine the level of obstruction and as well as the cause of obstruction. And this is a case of gallstone ileus, where if you look to the upper section, and you can see faint air loculi within the biliary tree, and lower down you can see this stone within one of the small bowel loops with proximal dilatation and air fluid level, which can also be appreciated in this sagittal reformatted image. Then the bezoar is very common actually in the stomach, but may reach the small bowel, and the trichobezoar or the phytobezoar may be are foreign bodies made of either hair or some of the vegetables that are undigestible easily, and they are impacted anywhere in the gastrointestinal tract, especially in the stomach. But sometimes they are seen in the small bowel, and this is an example of a trichobezoar in the distal ileum, and you can see the dilated bowel proximal to it with multiple air fluid levels. In this case you can see a hernia, and this hernia has entangled one of the small bowel loops, and this small bowel loop is incarcerated inside the hernia with the resultant dilatation of the other small bowel loops and air fluid levels. And you can also see this ectopic kidney and the left iliac fossa. You have seen this example before with post-operative adhesions resulted in a small bowel obstruction with multiple air fluid levels. Then pneumoperitoneum, meaning that there is air inside the peritoneal cavity. And the most two common causes by far for pneumoperitoneum are recent surgery and perforated viscus. And you know that pneumoperitoneum after surgery will resolve in about 3 to 7 days after abdominal surgery. And if there is no history of recent abdominal surgery and you see air within the peritoneum, and this is considered a surgical emergency because it indicates that the bowel is perforated, either post-traumatic or after laparoscopy, after perforation of the peptic ulcer, for example, or secondary to infection. Then the chest X-ray in the erect position is the best radiological investigation for the diagnosis of intraperitoneal air. But whenever you are not able to obtain an erect position, an erect view for the chest, then you may have this decubitus film or lateral horizontal beam where the patient is lying supine and the X-ray tube from one side and the film is on the opposite side, and here you can see air which is located between the liver and the diaphragm. Then in the CT scan, in order to be sure about the presence of air in the peritoneal cavity, you should use the lung window in order to confirm and to differentiate between air in the bowel and air in the peritoneal cavity. And you can see here that the presence of air in the peritoneal cavity as well as in the bowel will result in visualization of the bowel wall in the plain film, and this is what we call the regular sign, where air outlining both sides of the bowel wall so that you can see the bowel wall. And if you look carefully here, you can see the wall of the stomach very clear, and you can see also the wall of this intestinal loop very clear, and you cannot see that unless there is air inside and air outside, and this is the regular sign. Then whenever you see the wall of the bowel, the stomach or the small intestine is very clear, then you should suspect the presence of pneumoperitoneum. In the chest X-ray, there is a syndrome which is known as Chiladetti syndrome, where the colon is interposed between the liver and the diaphragm, very common on the right side, but can occur on the left side. And sometimes this syndrome may be mistaken for pneumoperitoneum. But the clue for differentiation is the presence of multiple linear shadows within the air underneath the diaphragm, indicative of the hostra of the colon. But in cases of pneumoperitoneum, you cannot see these transverse bands or the vertical bands because there is only air and no bowel wall. But if you see these hostra, you know that this is what we call Chiladetti syndrome. And whenever you are suspecting perforation of the bowel, you may give the patient oral contrast. And if the bowel is perforated, you will see that the orally administered contrast medium is in the peritoneal cavity. And this is a helpful sign to confirm the diagnosis of perforated bowel, but is not helpful to identify the site of perforation. Then if you see air in the peritoneal cavity, this is an indication of bowel perforation. And if you give the patient oral contrast, you can confirm the diagnosis of bowel perforation, but you cannot know the site of the perforation. Then we came to the acute abdominal conditions secondary to visceral involvement, and one of the common causes is cholecystitis. And the inflammation of the gallbladder is easily diagnosed clinically as well as by ultrasound, and we may use CT, for example, or the plain X-ray to show some radio-opaque calculi in the region of the gallbladder. And this is an example of numerous faceted radio-opaque stones in the gallbladder region, and this is an ultrasound showing the classic appearance of gallstones within the gallbladder with posterior acoustic impedance. And in this CT scan, you can see the gallbladder with multiple numerous small radio-opaque calculi. And the incidence of gallstones is about 10% in general populations, and the risk factors, as you all know, include obesity and pregnancy and estrogen therapy, and also in some cases of weight loss. Cholesterol stones are by far the most common, representing about 80% of the gallstones, and most of the gallstones are asymptomatic, and sometimes they are the cause of biliary colics. And here the ultrasound is of course the most common and reliable imaging modality for assessment of biliary calculi, and you can see the typical appearance in this ultrasound examination. Also, one of the non-invasive techniques is MRCP, and you can use the MRI to produce an image like this showing the biliary radicals, the common bile duct, and the gallbladder, and this is part of the duodenum, as you all know. And in the common bile duct you can see too many calculi, and also in the gallbladder you can see calculi. And this is the MRI appearance of a gallbladder stone, and this is the MRCP appearance of gallbladder calculi as well as distal common bile duct stone. Then you remember in the lecture of normal anatomy that the head of the pancreas is identified by the presence of the superior mesenteric artery and the superior mesenteric vein. And inside the head of the pancreas you can see a small hypodense dot which represents the normal common bile duct. But sometimes there is a stone in the common bile duct, and this is the head of the pancreas. This is the superior mesenteric artery and vein, and you can see the common bile duct is dilated with a stone inside, what is known as the meniscus sign. Then with the use of multi-detector CT, you can reconstruct the images along the course of the common bile duct. And you can see here, this is the portal vein, and this is the common bile duct, and you can see a stone in the distal part of the common bile duct. Cholangitis is one of the causes of acute abdomen, and the cholangitis is not an easy clinical diagnosis, but it can be diagnosed by imaging. And these are the commonly responsible organisms like E. coli and the enterococci. Then the diagnosis of bacterial or biogenic cholangitis depends on the presence of dilated biliary radicals, beaded appearance of the biliary radicals. Some of the ducts are markedly dilated, then some strictures and others are dilated. Then what's more important is the presence of calculi inside the dilated ducts, and the presence of calculi is highly suggestive of this cholangitis to be of bacterial origin. And you can see this is a very good example for bacterial cholangitis, and you see the dilated ducts containing too many radio-opaque calculi, and calculi are also present within the dilated distal part of the common bile duct. Also, you can use the MRCP for delineation of the biliary system, and whenever you see this classic beaded appearance of the bile duct, and you can easily diagnose the presence of cholangitis. Then sclerosing cholangitis is a chronic idiopathic inflammatory process of the bile ducts, and it may be associated with ulcerative colitis in some cases, as you know. And these lesions are usually diagnosed by the presence of multiple dilatations and the strictures of the biliary radicals, intra and extra hepatic. These sclerosing cholangitis may be complicated by biliary cirrhosis, portal hypertension, and cholangiocarcinoma in some cases. Then the imaging of cholecystitis, as you know, the gallbladder, whenever it is inflamed, the gallbladder wall will be thickened, and if you use the CT scan, you will see enhancement of the gallbladder wall. And in both ultrasound and CT, you can see some fluid around the inflamed gallbladder, what we call pericholecystic edema. Then you may see calculi, or you may not see calculi, and this is known as acalculous cholecystitis in cases of absence of calculi, and calcular cholecystitis whenever you detect calculi. And sometimes you can diagnose perforation of the gallbladder by CT and by ultrasound, and here you can see this small perforation in the wall of the gallbladder. The gallbladder wall is thickened and enhanced, and you can see the leakage of the bile in the pericholecystic area. And whenever you identify the hugely dilated gallbladder with thickened enhanced wall and the edema, as well as enhancement of the adjacent liver parenchyma, then you know that you are dealing with gallbladder emphysema. And of course, if you see the gallbladder which became contracted and small, and the wall is thick and irregular, and the presence or the absence of biliary calculi, then you think that you are dealing with the chronic cholecystitis. Actually, I will discuss the biliary problems in full details in a separate lecture, which will deal with biliary tract imaging. Then emphysematous cholecystitis is a disease of diabetic patients, and can be diagnosed by the plain film whenever you see gas in the region of the gallbladder, and is also an easy CT diagnosis whenever you see that there is gas in the wall of the gallbladder, or even inside the lumen of the gallbladder. Acute pancreatitis, one of the causes of acute abdomen, meaning that the pancreas is inflamed. And whenever the pancreas is inflamed, it will be swollen, and the peripancreatic fat planes will become dirty, or stranded, or smudged. And these are the basis for diagnosis of acute pancreatitis: swelling of the pancreatic gland, hazy, strandy, or smudged peripancreatic fat planes. Then you may see some fluid which is the result of inflammation, and this fluid may be free or encysted. Whenever it is encysted, it is known as pseudopancreatic cyst, and whenever it is free, it's commonly accumulating in the anterior pararenal space between the kidney and the spleen. And also we have a separate lecture for pancreatic lesions and diseases. I will explain in details these issues. Then this is a case of acute pancreatitis, and you can see the pancreas is swollen, the pancreas is heterogeneously enhanced, and you see the peripancreatic fat is stranded, and here is some of the fluid accumulating in the splenorenal pouch, and you can see it along the border of the gyrata fascia here. This is the collection which is commonly seen in this place. Then accumulation of the fluid may be diffuse, as in this case, and you see the inflammation of the pancreas, which is swollen, heterogeneously enhanced, and these areas in the pancreatic tissue which are not enhancing as much as the head, for example, meaning that these areas are more or less ischemic or passing into necrosis, what we call necrotizing pancreatitis. Then whenever the fluid is encysted, and this is known as pseudo pancreatic cyst, and the pseudo pancreatic cyst is one of the known associations of acute pancreatitis. Then a well-known cause of acute pancreatitis is the ERCP, and sometimes whenever the patient is examined by ERCP for any reason, this examination may result in the development of acute pancreatitis, which is not different from the acute pancreatitis for whatever etiology. And here you can see that the pancreas is swollen, and all parts of the pancreas are homogeneously enhanced, and you see extensive fluid in the peripancreatic area as well as in the perirenal area on both sides. And this is the difference between the normal pancreas and the necrotizing pancreatitis, where you can see heterogeneously enhanced, the swollen, diffusely swollen pancreas with multiple areas of no enhancement, representing the necrotic pancreatic tissue. And also you can see the heterogeneous or the strandy appearance of the peripancreatic fat planes. And this is a case of pancreatitis with pseudopancreatic cyst, and you see the encysted fluid related to the region of the pancreatic tail. Then whenever you see a cyst related to the pancreas and it contains air, then you are sure that this is a case of pancreatic abscess. Then the difference between pseudopancreatic cyst and pancreatic abscess lies in the detection of gas within the lesion. Whenever you see gas within the lesion without any history of previous interventional maneuvers, then you may think that the pseudopancreatic cyst have been turned into an abscess. Splenic infarctions have too many underlying causes, and there may be single or multiple, and will appear as wedge-shaped hypodense lesion reaching the splenic capsule without deformity of the splenic contour. And in chronic cases, the calcium may be seen within splenic infarctions. The causes are a lot, like embolic causes, local thrombosis, and splenic malrotation, and cases of pancreatitis with thrombosis of the splenic vein, in cases of AIDS, sickle cell disease, and some of the iatrogenic causes. Then this is massive splenic infarction. This is the pre-contrast scan, and after injection of contrast you see normal enhancement of the liver and almost no enhancement of the spleen apart from a very small area of healthy splenic tissue. Then acute appendicitis is of course one of the causes of acute abdomen, and the normal appearance of the appendix in the barium enema is like this one. But remember, if the appendix is not filled with barium, this does not mean that it is obstructed or it is inflamed. And in the CT scan, you may see the normal appendix as a small tubular shadow filled with air in the right iliac fossa. And the acute appendicitis occurs whenever the appendix is obstructed by any food residue or by foreign body or by tumor, for example. This will result in increased intraluminal pressure and venous engorgement and arterial compromise, tissue ischemia, infarction, and maybe sometimes perforation. Acute appendicitis is basically diagnosed whenever you see the appendix which is edematous and the wall is thickened and the area around the appendix shows some fluid. And all these informations can be obtained by the CT and also more easily by ultrasound. And what's important is to detect an appendicolith. And this appendicolith is a small calcified lesion which is usually accused to be the cause of obstruction and the initiative for the development of acute appendicitis, but this is considered by radiologists as one of the landmarks for the diagnosis of acute appendicitis. But the plain film, whenever it shows the appendicolith, which is will be a small calcified lesion in the right iliac fossa, may point to the diagnosis. But if not, you cannot see any abnormality in the plain film. And in the CT scan, you may assume that this is the appendix, and you can see that the periappendicular fat plane is stranded or smudged. But the detection of appendicolith will make the diagnosis a little bit easy. And this is the reconstructed image along the course of the appendix. You see the appendix wall is thickened and enhanced, and you see inside the appendix fluid as well as air. And normally you know that the appendix contains air. And here is the classic appearance of acute appendicitis. The appendix is distended with fluid, the wall is thickened and enhanced, and very importantly, you can see this appendicolith or the calcified shadow within the appendicular lumen. And here are the findings: dilated appendix greater than 6 millimeter, appendicolith with appendicolith is an indicative of acute appendicitis, and periappendicular fat plane stranding denoting the presence of inflammation. Then we came to the epiploic appendicitis, and this is inflammation of the appendices epiploica. And the appendices epiploica are just fat projections related to the colonic wall, and these projections are not usually seen in the CT scan unless the patient has fluid in the peritoneal cavity. And you see here, this is ascites, and all these small fat containing lesions related to the colonic wall represent these appendices epiploica. And whenever these appendices epiploica are inflamed, usually due to torsion, being freely mobile and is usually subjected to torsion, then this will result in localized inflammation related to one of these appendices epiploica, and the patient may got acute abdomen. And the CT findings will show this the classic appearance, which you know that this is a fatty lesion, and if you look carefully here, and you can see fat which is surrounded by a ring of inflamed peritoneal surface, and outside the inflamed peritoneum you can see the stranding of the intraperitoneal fat. And sometimes you can see a central dot representing the thrombosed vessel inside this appendices epiploica, but this is not evident in this example. And here is the drawing showing the findings. Here you can see the thrombosed vessel and the fat of the appendices epiploica and the thickened visceral peritoneum inflamed around the lesion. Then if you look carefully here, sometimes you cannot see the lesion because of being hidden within the bowel loops. But if you look carefully here, and you can see the lesion where you see the thickened visceral peritoneum with stranding of the intraperitoneal fat. And this is the magnified image, a small magnification, large magnification, and you can see the lesion better in the magnified images. And in this patient, you see the classic appearance of inflamed ependyses epiploica, and you see this lesion in the left iliac fossa and the central thrombosed vessel surrounded by the thickened, inflamed visceral peritoneum. And then there are a lot of causes for colitis, including the pseudomembranous colitis and other bacterial infection of the colon. This issue will be discussed in full details in the lecture of imaging of the colon, but here colitis is one of the causes of acute abdomen. And here you can see the diffuse thickening of the colonic wall, slightly encroaching on the colonic lumen, affecting the rectum and the sigmoid colon. Diverticuli per se do not cause acute abdomen, and this is diverticular disease of the colon, uncomplicated. And by barium enema, you see multiple diverticular outbouching, classically or commonly seen on the left side of the colon, but can occur anywhere. And in the CT scan, you can see multiple buckets filled with air along the colonic wall. And very importantly, the fat planes around the colon are preserved. Then for the diagnosis of diverticulitis by barium enema, for example, and you see that the colon, there are multiple diverticuli, and the segment affected by diverticulitis is spastic, edematous, and irregular in outline. Then you can see here this very spastic area with associated some diverticuli in the colon, which will help you to diagnose the diverticulitis, especially in acute presentation of the patient. And this may be mistaken for malignancy, but the presence of diverticuli and the acute condition or the acute presentation of the patient will help to differentiate both conditions. And by CT scan, the diagnosis of diverticulitis depends on the reticulations and the stranding of the pericolic fat planes. And you can see multiple buckets of air along the wall of the sigmoid colon, and the fat planes around the involved colon are stranded or smudged, as you can see. And this is also an example of acute diverticulitis, where you can see the colonic wall is thickened, multiple buckets of air along the colonic wall, and the pericolic fat is stranded. And these findings are very important. Number one, the presence of buckets of air in the colonic wall representing diverticuli, the presence of mural thickening of the affected part of the colon, and very importantly, the smudging or the stranding of the pericolic fat planes. And this is also a case. You see marked thickening of the colonic wall, and you see the buckets of air filled with air in the wall of the colon, and the smudging of the pericolic fat planes. Then the Meckel's diverticulum is a representation of incomplete atrophy of the omphalomesenteric or vitelline duct. And this is a true diverticulum on the antimesenteric border of the ileum. And many of the books will state this rule of two, as 2% of populations are affected by Meckel's diverticulum, and this diverticulum occurs about 2 feet proximal to the ileocecal valve. This diverticulum is about 2 inches long and 2 centimeters wide, and it contains 2 types of heterotopic mucosa, particularly the gastric and the pancreatic mucosa. And the 2% of the patients with Meckel's diverticulum will have symptoms. Then the diagnosis of Mickels is very difficult. Actually, via the small bowel enema or by the CT scan, it is very difficult because this diverticulum is usually hidden within the overlapping by the different small bowel loops, but it needs a very high clinical suspicion in order to diagnose this Mickels diverticulum. Then this diverticulum may have a lot of complications, particularly the bleeding. And this bleeding is commonly seen in the pediatric age group because of the presence of heterotopic gastric mucosa, which can ulcerate and cause hemorrhage, and the presence of occult blood with stools may cause iron deficiency anemia in adults. And this is what we call the Mickels scan, and you use the technetium 99M pertechnetate scintigraphy, and this isotope particularly taken by the gastric mucosa. And if there is a hot spot in the right iliac fossa or the right lower quadrant of the abdomen, which is the most likely the site of Mickels diverticulum, and you can somewhat sure that this is Mickels diverticulum containing gastric mucosa. Then the Mickels diverticulum, other complications apart from hemorrhage, it may result from a small bowel obstruction, it may be inflamed and perforated, and it may contain an enterocolith or a calcified lesion, or may develop a neoplasm like the carcinoid tumor. Then this is the coronal reformatted CT post-contrast image of the abdomen, showing an inflamed lesion here, which is approximately the site of Mickels diverticulum. And you see the lesion with stranding and smudging of the pericolic fat planes. Then Crohn's disease is one of the inflammatory bowel lesions which particularly affects the terminal ileum, and this will be also explained in full details in the lecture of small bowel imaging. And one of the common manifestations of Crohn's disease in the terminal ileum is stricture with rose thorn appearance because of the minute ulcers along the of the mucosa of the affected part of the ileum. And too many other diagnostic criteria like the skip lesions, the cobblestone appearance, and too many will be explained later on. Then this is Crohn's disease by CT. You see this is the urinary bladder, and here is the terminal ileum, and you can see marked mucosal thickening encroaching significantly on the lumen with stranding of the peri-intestinal fat planes. Small bowel ischemia is also one of the causes of acute abdomen, and the causes of small bowel ischemia may include arteriosclerosis, especially in diabetic patients, and vasculitis, mainly in cases of polyarteritis nodosa, cardiac failure, and severe hypotension. And the small bowel ischemia have too many appearances in the in imaging, and you can remember the thumb printing or the mucosal edema due to ischemia, and also the presence of gas in the ischemic or necrotic bowel. And one of the signs is the presence of gas within the portal venous system. And this is a very bad indication of this is an indication of very bad prognosis whenever you detect air in the portal system, which means a fulminating disease, and this patient have died shortly after the diagnosis. And peritonitis can be the sequelae of bacteria or granulomatous disease like TB, for example, or chemical irritation. and the peritonitis is diagnosed by the presence of diffuse enhancement and thickening of the peritoneal surfaces, together with the presence of multiple abscesses within the peritoneal cavity, showing marginal enhancement, and multiple fluid collections may contain air. And this is a CT appearance of a case of peritonitis, and you can see the peritoneum is markedly thickened, and the small bowel loops are amalgamated within the inflammatory reaction within the peritoneal cavity. And this is peritonitis with multiple free and insisted peritoneal collections, and the collections show thick enhancing margin, and they may contain air loculi representing intraperitoneal abscesses. Of course, the renal calculi or the ureteric calculi with resulting in acute renal colic are considered one of the causes of acute abdominal conditions. And now you know that CT-UT is one of the commonly used techniques for diagnosis of a small undetectable urinary tract calculi, I mean by ultrasound and by the IVB. And then you can, by this technique, you obtain multiple sections from the level of the kidney down to the end of the urinary bladder, and these sections are taken at 3 millimeter intervals, and you look carefully for the any radiopaque shadow along the urinary tract. And if you see these images, and you can see this radiopaque shadow, which is you can appreciate that is away from the ureteric course. But these images are very important, which are coronal reconstructed images along the ureteric course. They should be obtained in every case in order to facilitate and make the diagnosis is more or less easy. And the previous images, you can see this radiopaque shadow, which represents the flibulus, and you can confirm this by looking at the ureteric course, and you cannot see any radiopaque shadow within the ureter on the right side or on the left side. But these are two different cases to show the appearance of ureteric calculi by the coronal reconstructed CT images, one in the distal part of the ureter and one in the proximal part of the ureter. And this is a good example for a minute stone located at the vesico-ureteric junction in the axial image, but you are sure here from this image that the stone is actually located in the distal part of the ureter with proximal mild back pressure changes. Then these renal conditions, as I have said, will be discussed in full details in the lecture of renal of urinary tract imaging. Then acute conditions in the kidney, like acute pyelonephritis, acute glomerulonephritis, renal vein thrombosis, all these changes will result in some imaging criteria, which will include that the affected kidney is swollen and its function is relatively poor compared to the opposite kidney, and the perinephric fat is stranded. And this is a case of acute pyelonephritis of the right kidney. The kidney is swollen, the function is relatively deteriorated compared to the opposite kidney, and the perinephric fat may be stranded. What's very important is what's known as the striated nephrogram, and here you can see striated non-enhancing areas within the nephrogram, which is one of the criteria of acute pyelonephritis. And here another case, the kidney is swollen compared to the opposite one, and you see these striations within the renal parenchyma due to acute pyelonephritis. This is also a case of acute pyelonephritis. The kidney is swollen, there is a striated nephrogram, and you see the perinephric fat planes are stranded and smudged, and you can also see the diffuse thickening of the Gerotta fascia as well. Epithematous pyelonephritis is a disease of diabetic patients, and in these conditions there is a severe inflammation of the kidney by gas-forming organism, and the kidney and the perinephric space are full of air, as you can see here in this CT image of epithematous pyelonephritis of the left kidney. And finally, the aortic lesions, which may result in acute abdomen, like aortic aneurysms whenever they leak, or the aortic dissections. The aneurysms occur approximately in about 4% of the population, and they are commonly due to arteriosclerosis. And rupture of these aneurysms may have a mortality of 50 to 90% of cases. And the diagnosis of leaking abdominal aortic aneurysm requires a very rapid imaging techniques in order to confirm the diagnosis and to interfere with the patient to stop this leakage. And the availability of multi-detector CT has facilitated this very rapid imaging. And here you can see this is the aorta, which is aneurysmally dilated, and you see a huge area around the aorta representing the leaking aneurysm. And in this case, you can also see this is the aneurysm of the aorta, and this is the leakage around the aorta. This is the patent lumen, and this is a thrombosis within the aneurysm of the aorta, and you can easily appreciate the site of leakage. And you have seen this before as an example of leaking aortic aneurysm, and this is also a leaking aortic aneurysm. You see the leakage of the contrast around the aneurysmally dilated aorta, and also you can see this relatively blood which is located in the retroperitoneal area around the aortic leak. Then the CT scan is also one of the non-invasive techniques to assess the patency of the stents or occlusion of the stents, as in this case. And you can see this is an aortoiliac stent, and the right side part of the stent has been occluded. And the section is also an easy diagnosis by the use of contrast enhanced CT scan, where you can identify the intimal flap, and you can appreciate the extent of the section within the branches of the aorta, like the superior mesenteric artery and the other branches. And whenever you have the reconstructed images in 2D or 3D planes, you can appreciate the extent of the intimal flap throughout the aorta and the involvement of the iliac arteries if present. And this is an example of dissecting aortic aneurysm affecting the descending aorta, which is markedly dilated. And you see that the intimal flap is affecting the aortic lumen and not affecting the superior mesenteric artery. And in the reconstructed image, you can see the extension of the dissection into both common iliac arteries. And this is the dissection which has involved with the left renal artery, resulted in left renal infarction. And you see the intimal flap, and you see that the right kidney is well perfused and the left kidney is not perfused due to the dissection of the aorta has involved with the orifice of the left renal artery. هذا وبالله التوفيق والحمد لله رب العالمين.